Let me first tell about Anita Singh Madam. She is the Vice President of FOGSI of East Zone. So we had her CV also, no? Can you show the CV?
Bhagya, yeah, that will do. I think it should go on.
And she is in charge of the oncology committee, and we have together done lot of good work. So welcome Anita Singh Madam to this webinar, and this is a little different kind of webinar in which we'll learn some new technologies. So we have with us Dr. Usha Saraya Madam, and request Anita Singh Madam to please introduce Usha Saraya Madam.
Okay.
So please share Madam Usha Saraya Madam CV.
Thank you, Dr. Bhagyalakshmi. And before the formal CV is there, actually I cannot see Madam Usha Saraya on the screen. Is she there?
Can we stop sharing for a minute so that we can see each other and then we can share? Please stop share.
Madam is already there?
Yes, Madam. Yes, Madam.
So, my regards to Madam Usha Saraya. And in the field of gynecological oncology, I think Dr. Usha Saraya Madam is one of the strongest pillars of our organization as far as oncology part is concerned. And she has devoted herself to, especially to the screening protocols and how to manage their action of carcinoma cervix, since we have come to know about this disease protocol screening procedures. And she was the one who has popularized it all over India and worked hard to minimize the burden of this disease in our country. Can I have a CV, please?
Can you share Usha Saraya Madam CV? Oh, sure.
She has been imparting training to a large number of doctors regarding the screening for cervix by various techniques, especially colposcopy and all that. Can you please share the CV?
I'm just trying to share.
Can you share Madam CV, Parvati?
Yes, ma'am. I'm just trying.
And
it's okay if you don't have it. It doesn't matter. You have
actually, Dr. Usha Saraya has been present in our programs of gynae oncology webinars. A number of webinars she has attended as chief guest corner, chairperson. In every position she has attended it, and she enjoys attending all the programs and always give her comments, her ideas to all the programs wherever she is present. So I am thankful to you, Madam Dr. Usha Saraya, for so much encouragement and good wishes for this committee and the success of the webinars. For you being present most of the time, whenever we invite you, you are there. Thank you, Madam. And with this introduction, I think everybody knows about her. So I present Dr. Usha Saraya Madam to say a few words on this occasion.
Hello, can you hear me now?
Yes, Madam.
You can remove the image from the
screen. Stop share, Parvati. Please stop share.
Yes. Yeah. So thank you very much, Bhagya, for again giving me this opportunity to share my thoughts with you. And thank you very much, Dr. Anita, for all the kind words you have said about me and my interest in the subject. And today we are meeting to discuss and to familiarize ourselves with this new technology of thermal ablation. Although it has been recently accepted by WHO as a modality of treatment for CIN, we have known about this technology for many years. It was developed first by Kurt Stem of Kiel. And Kurt Stem was a personal friend of ours. He came to India many times. And he had shown us all this equipment for so many years. Then he used to call it cold coagulator. That was the name before. And since then, it has been modified substantially, and now it has come back as a very suitable modality for treatment of CIN. Please always note that it is an ablative procedure, and not an excisional one. So we are here today with many experts who will explain to us how to use it and how to introduce it in our practice. Make for you today, and that is the women who are treated for CIN, they need a 20-year-long follow-up. Now, that is almost like you can say a lifetime follow-up. And there are two excellent studies which are published, and they are very long-standing studies of over 16 years follow-up. One is by Strander from Sweden, and the second one is from Melnikov and Megliani from British Columbia in Canada. And these are extensively quoted by WHO's in the manual. And both the studies have indicated that maximum recurrences occur in the first 6 years of after treatment. So that period is very important. And secondly, the overall incidence of cervical cancer in women treated for CIN during follow-up was 37 per 100,000 women. Whereas in the normal cohort, it was only 6 per 100,000 women. So you can imagine the magnitude of numbers of patients who will at some stage get a recurrence. And we have to be very, very careful and cautious about this. So I come again to the problem that we have no such long-term studies in our country. I myself have a department which is 50 years old, and we do have some follow-up, but we do lose patients to follow-up, and in this floating population of Mumbai, it is very difficult to trace our patients. So we must always keep this in mind and give the responsibility of reporting for follow-up to the patient and tell her that it is in your interest to be in touch with us and to be regular with your follow-up. So I just want to end by saying that we learn from the past, we act in the present, and we plan for the future. But all these things we have to do simultaneously. So just as we begin to use new technology in our practice, let us plan for the future also and include a close follow-up as a part of our routine. So before I end, I want to wish you all a very happy Diwali and wish you peace and good health and happiness in the coming year. And best wishes for this seminar, which is going to be very interesting, very informative, and something we can learn to use very easily. Thank you very much, Bhagya, and thank you, Anita, and thank you, Mala, and thank you all the people who have joined today to listen to this seminar. Thank you.
Dr. Coagulation, would you like to go ahead? Thank you so much, Dr. Sathuraya, for those great words. Dr. Coagulation, would you like to introduce the next speaker? Okay, I'll invite Dr. Ramani Devi to say a few words. I'll give a brief bio about Dr. Ramani Devi. She is the Managing Director of Ramakrishna Medical Center and Janani Fertility Center in Trichy, Tamil Nadu. She is a National Vice President of FOGSI 2020 and has been an International Board Advisor of the Fertility Society of Bangladesh. She has presented several papers in both national and international conferences such as FIGO Kuala Lumpur, FIGO Vancouver, and RCOG London. She has authored 15 topics for books and holds 12 scientific papers to her name. Dr. Ramani has also won several awards over the years. She is a recipient of Dr. C.L. Jabiri Symposium of the Year 2019, Best Woman Doctor Award by the Tamil Nadu State Association in 2019, Dr. Dhuru Shah Distinguished Community Award.
I can introduce Dr. Mala Arora.
Sure, definitely.
Over to show her CV.
Definitely, I will. You can do that at the end. Thank you, Dr. Ramani Devi. So please go ahead, Dr. Ramani Devi. We would love to hear from you.
Yeah, I have great pleasure in introducing Dr. Mala Arora, who is a great friend of mine and is a very down-to-earth person. And she is the chairperson of ICOG 2017 and vice president of FOGSI in 2011 with RCOG UK, FICOG, FIC-MCH. She has edited the yearbook of 2018 and 19, chief editor of first trimester of pregnancy, chief editor recurrent pregnancy laws, 2003, 2007, 2008, and chief editor of World Clinics of OBGYN, volumes 1 to 10. She has won the DC Datta Award for the yearbook of OBGYN in 2018 and 19. See, more than that, I had the opportunity of working with her as a guest editor for one of the World Clinics of OBGYN. It was a pleasure working with her and such a nice personality. And I am very happy that I have been given the opportunity of introducing Dr. Mala Arora. Thank you for the opportunity given.
Thank you, Ramani. Thank you for your kind words. And thank you, Bhagya, for inviting me to this very important webinar where you are going to teach your delegates the skill of using thermal ablation. I know cancer cervix is one of the cancers that we want to eliminate, and every new technology adds to the cure rate and elimination of this cancer. I was just reading, I'm not an oncology person, I must admit, but immunotherapy is coming in, ablation is coming in, radiotherapy was always there, and with the vaccine available to the masses, I think we should be in a position to fight cancer cervix at every level in every strata of society. So thank you very much, and I will keep logged on to see the proceedings of this webinar because I find it very interesting. Thank you again.
Perfect. Thank you so much, all the doctors, especially Dr. Bhagyalakshmi, Dr. Mala Arora, Dr. Anita Singh, Dr. Ramani Devi, and Dr. Usha Suraya. So without further ado, good evening, everyone. And my name is Dr. Nitin Puraka. I am the founder and director at ZEPNURhealth. So we have a very informative and insightful session today on thermal ablation. And we have several subject matter experts from both FOGSI Oncology Committee as well as the FOGSI Food, Drug and Medical Surgical Committee. We're also happy to have several reputed doctors and experts in this field and look forward to hearing from all of you as the session progresses. So just before I get into the session, just wanted to let the attendees know that during the course of the session, if you have any questions that you would like to ask the panelists, please feel free to use the chat box function, and I will try my best to get the queries answered by the doctor. Also, keep your eyes open in the chat section. We will be conducting a few polls, so feel free to participate in them during the session. So great, let's get right to the session. Our first speaker will be presenting on FOGSI GCPR screening of cervical cancer. And Dr. Bhagyalakshmi will be introducing the first speaker. And before passing on to Dr. Bhagyalakshmi, I'd like to give a little bit of a background about Dr. Bhagyalakshmi. She is the chairperson of the Oncology Committee at FOGSI and associate professor at the Department of Gynec Oncology in Qatar. She was the governing council member at ICOG Elect, vice president at AOGI in India, and joint secretary at AGOI. She is the assistant editor at the Indian Journal of Gyno-Oncology and the peer reviewer at Indian Journal of Surgical Oncology. Dr. Bhagyalakshmi has been awarded Dr. Abha Singh Oration, Raipur in 2019, and Dr. Cyril Mehtaji Guest Lecturer Award at Mumbai in 2019. She is also an executive member of the ISCCP. So, Dr. Bhagyalakshmi, over to you.
Thank you so much, Dr. Nitin, for those kind words. So, it's a real pleasure to introduce a close friend, Dr. Vidya Thobi. I think her CV is in front of you, but more than that, I'd like to tell you that she is a very hardworking, very avid worker. I think anything she takes up, she really works with her heart and soul. And very recently, she has got the best committee award also from FOGSI. So it's called the Mehru Dara Hansotia Best Committee FOGSI Award in just 2020. She is also the ICOG Governing Council member from 2021 to 23, will be taking over office, and she has got the FOGSI Champion Award and many more things. And she hails from Bijapur and works as a professor there in the medical college. So over to you, Dr. Vidya, and I think we all will enjoy listening to her.
Thank you, Dr. Bhagyalakshmi. I think, Akanksha, if you could unmute Dr. Vidya.
Hello? Hello? Hello, am I audible?
Yes, you are, Dr. Vidya.
Yeah. So, good evening to everyone, and I thank add on to her committee for this webinar. We were thinking of something, but the thermocoagulation was such an instrument which can have a preventive role in the reducing the burden of cancer cervix in India. So I thought this was a good opportunity, and thank Dr. Ramani, Dr. Rama have joined and so wishing a very happy Diwali to all of you. And I just want you to know that this cancer screening guidelines FOGSI has brought in 2018 under able chairmanship of Dr. Neelja Matla, and Dr. Bhagya was also a part of this guideline. So I'll just go through, and my talk is based on these GCP guidelines. I'm just logging in from my mobile, so the share screen will be done by the backdrop. So I bring greetings from Food, Drugs and Medical Surgical Equipment Committee, and we all of us know that cervical cancer is a major public health problem, and it is most common cancer among Indian women. So this paper cutting is from 2018. So if you see the incidence, it is the second commonest cancer amongst the women. It is the first common cancer in India, and current estimate indicates approximately more than 1 lakh new cases diagnosed every year, and around 74,000 deaths annually in India. So it accounts nearly 1/3 of the global cervical cancer deaths in the developed state. Okay, so WHO urges nation to pace up the efforts, and Dr. Bhagya has planned various activities on this 17th of November. So what are the methodologies are inspection, just change on slides and speak, because I'm not able to see the slides properly. So I'm just speak. Okay, so Cervix is amenable to screening by number of methods, which include visual inspection, magnified via, that is via M, and visual inspection with Lugol's iodine, Willi, and cytology. Hpv DNA. So overview of this screening test, like acetic acid is applied as via we do. Acetic acid is applied to the cervix to identify precancerous and cancerous lesions, and we have to know that the strengths and limitations of via. If you see that strengths are it is cheaper than cytology, and we can even screen and treat whenever we are doing via. But the limitation, if you see that it is variable. from low to moderate sensitivity to the specificity when we see the lesions CIN2+. And sometimes we have the possibility of over-treatment. So acetic, one thing one should remember that acetic acid must be prepared directly before screening. And it is, we all also know that it is because via family does not improve. Also it requires application of the leukocidin. It requires less training. It is cheaper than cytology, gives immediate results, and it is also a potential immediate results we get, and potential immediate treatment also can be done. And leukocidin has got 1 month shelf life. That is the advantage, whereas acetic acid preparation should be done freshly. So it has a possibility of over-treatment again. So next slide, please. If you see the cytology, samples are taken from the transformational zone of the cervix and sample is smeared onto the glass slide. And this glass is sent to a laboratory for the reading by the cytologist. This is how we do. It has got a high specificity for CIN2+, and the limitations are relatively of a low sensitivity, requires laboratory and specialized technical lag in the test result, which can contribute to the loss to follow-up and which can also delay the treatment. If you see the delay, sometimes more than long duration of training of the cytotechnician is also required for the getting the report. If you get the test and send to the laboratory analysis for the trained technicians, it has got a high specificity and sensitivity for HPV infection, requires minimal training, and even women can collect the cell sample. This is the strength. And then it has to be followed again. This is a limitation, that it has to be followed by the test for the dysplasia, which requires the laboratory and trained technicians. And then also there is the lag in test result can contribute to the loss of follow-up and delay the treatment. So the advantage of this DCPR guidelines of FOGSI is it all goes by the settings. If you have not a good resource settings, primary where we can do the primary HPV test or co-testing or cytology or via, all these tests can be done in a good resource setting. And then we can have a triage tools like cytology with the newer modalities or via and biopsy. Are also always like and thermal coagulation. And in the single visit approach, we can have see and treat approach. Whereas in limited resource setting, we can have only via. Even in the camps, we can take up this via. And of course, at camps, we cannot take colposcopy. But in a smaller PHC and all, colposcopy if available, then you can have the colposcopy directed biopsy. The management options are cryotherapy, LEAP, conization, and thermocoagulation, which we are going to witness today, of various modalities. And the single test approach, visit approach, which can have the screen and treat or screen, see and treat. These are the settings, good resource settings and limited resource settings. And if you see the modalities in good resource setting, as already we have discussed, the target age group is in the good resource setting is 25 to 65. And in limited, we can extend up to 30 to 65. And postmenopausal women screening of with via may not be effective. Now, we always start the cytology at 25 and primary HPV testing and co-testing at 30, via at 30. And frequency, the primary HPV testing or co-testing every 5 years and cytology every 3 years. In limited resource setting, you can extend this to the years or at least 1 to 3 in lifetime. Resource-based cervical cancer screening recommendations. So when to stop this screening procedure? One is 65, at the age of 65 with consistent negative results in last 15 years, or women with prior screening should undergo test once in 65 years, and if negative, they should exit the screening. And if you want to have the follow-up methods after the treatment interval, Hpv testing or cytology every 12 months and via every 12 months. As Usha Saraiya madam was also telling that it is almost 20 years when we are screening and following the abnormal reports, CIN2+, irrespective of method of treatment. So the follow-up of these women is very, very important. When we go for the screening in hysterectomized women, we have to have the report that following hysterectomy, the cervix was removed for benign cause. There is no need of screening. Unless there is any history of any previous cervical intraepithelial neoplasia. So you should have a histopathology report. And if there is an absence of cervix, which must be confirmed by the clinical records or examination, because at my place, I get many places, some periphery, they have done hysterectomies, but the cervix is present when you do put the speculum. So you should be very careful to have the indications of hysterectomy, and the screening must be performed at the clinical discretion of the person who examines. The follow-up of women with CIN hysterectomy, the HPV report, need to be screened with HPV every 6 months and 18 months. Then HIV positive patients or screening of immunocompromised women start within 1 year of initiation of sexual activity. Then it should be done by, in good resource setting, Hpv testing, co-testing, cytology, or via every 2 to 3 years. So via is an affordable Hpv testing if it is available. Then you have to follow these patients every 3 years, at least twice, as often as general population. So these are the things one should have. These are the recommendation by our GCPR guidelines, and there are beautifully, they have given various charts, and they are very, very easy to follow. So I will just go through some of this one, and I will not go in detail with the management part. So whenever you are doing the visual inspection with acetic acid between 30 to 65 years, preferably up to 50 years, and if the result comes via negative, then you have to return to the routine 5-year screening protocol. If it is via positive, and then you can take up this patient for colposcopy and biopsy, and if it turns out to be normal, then again 5-year screening protocol can be done. But if the screening and it is positive, you can there and there only you can have screen and treat approach, and for that lesion should be visible and it should be eligible for these cryotherapy. You can do it there as screen and treat procedure. Now, if you see the via positive and Vili positive, next slide please. So here we can see after application of acetic acid, you can see the large aceto-white area around the os after acetic acid application. Can you change the slide please? And in Vili positive, after the Lugol's iodine application, the lesion is iodine negative. So these things you should remember, and then you can train them. Now, if you see the accuracy of Maya in detecting CIN2+ lesions, there are various studies right from 1996 up to recent one, and the largest study I'll take around 2003. If you see the sensitivity is around 60 to 83%, but specificity, if you see, the specificity ranges from 94 to 90%. So these are the accuracy of detection of CIN2+ diseases. Now, if you see the cytology, the next modality is the cytology, which requires the repeated test at the regular interval. Next slide, please. So regular interval, and you have, it is not visible everywhere. So it should have a high coverage. So these are the shortcomings of cytology. And this screening with Pap smear, if you see, the best time to do the smear is mid-cycle from 8 to 12 days. Should not have intercourse, put anything into vagina, and like doses and tampons and vaginal medicines, and the contraindications, of course, we know about the evidence of acute infections and absence of bleeding. So how to perform, next slide please, how to perform pap smear. I'll not go into the details, but everybody should know that you should always take a proper history, previous history of smear, positioning of the patient, and no lubricants, and you have to be scraping of the spatula should be 360 degrees, endobrush should be used, and rotation. These are very, very important guidelines one should know. And the spreading of the smear is also very important, how to spread the smear and how to send into the fixative, put into the fixative. So these are the important things which reduces the various errors. So why there is a high false negativity is around 15 to 50%, false positivity around 5 to 10%. High false negativity is due to many correctable simple problems like sampling errors, specimen fixing errors, and various limiting factors for this cytology are infection, bloody smear, lot of mucus, or any interpretation error also. So the cytologist who is interpreting it must be trained properly. So these are the limitations, and these limitations can be overcome. How to overcome this is we should have training, proper training, repetition of the smears, and we can also have the liquid-based cytology. Now, what should be the adequate smear? It should have cover at least 10% of the slide. It should be labeled properly, and it should have an adequate number of well-preserved, well-visualized squamous cells. So if you are using liquid-based cytology, 5,000 cells are that much is sufficient. So adequate representation of transformation zone are very, very important. So I'll not go into the liquid-based cytology, but the advantage of liquid-based cytology is same sample can be used for HPV DNA assessment. And even it facilitates computer-assisted screening. So a lot of artificial intelligence has come. So it is also called as automated cytology. And that's why it improves the sensitivity and detection rate of low-grade lesion as well. So next slide, please. Criteria of various single-visit approach strategies one should have. That is see and treat, screen and treat in colposcopy clinic. When there is a patient is referred with abnormal cytology report, colposcopy scoring indicates high-grade lesions, and simultaneous treatment if it is done, like excision and ablation, and when there is a low probability of over-treatment because of high specific cytology, and post hoc analysis of biopsy report and excision specimen. And in public health program at camps, when we do the screen and treat, when VIA detects the abnormal lesion, and there are criteria, and the criteria of ablation are fulfilled, treat immediately with or without biopsy, and there is lower probability of over-treatment in high prevalence area. And post hoc analysis is possible if you are taking biopsy from suspicious lesions or something. So we always have, whenever we are talking of cytology, we follow this bedside system of reporting cytology. We all know ASCAS, LSIL, HSIL, and all those things, and even the glandular abnormalities. And there are newer modalities of cytology-based screening, like in liquid-based cytology, we have CREAM-PAP and SurePath. And what are the advantage of these are few inadequate pap samples, and which reflects HPV testing, which is possible. Automated reading is possible, and the sensitivity is not better than the conventional one. But in 11%, it is more sensitive for LSIL plus lesions. But it is very, very expensive, not cost effective, and automated is not effective. There are various biomarkers also are coming up, which have the advantage of transforming HPV infection, which detects CN2+ lesions. We can try as a low-grade smears and can be done with histology and cytology slides. And it reduces the colposcopy referrals. So these are the things which have come up in the newer modalities of cytology-based screenings, like biomarkers SP16, NK4A, Syntac, and Syntac Plus. Now about the screening with cytology and management. So whenever we are doing get the report as ASCAS, when the patient age is more than 30 years, These patients, you just do HPV testing and you have to follow them cytology at 1 year. So if HPV is negative, then return to routine 5-year screening with HPV testing and co-testing. If it is positive, then you have to do colposcopy and colposcopy directed biopsy. Then if colposcopy is normal, then again do the co-testing with HPV at 1 year. Or if it is abnormal, then you have to follow the CIN management guidelines. And if cytology you do after 1 year, if it is negative, then routine 3-yearly screening with cytology you should do. And if the report comes at 1 year as ASCUS, LSIL, then again you have to do colposcopy and biopsy and follow the routine HGCPR guidelines. If the patient is non-compliant, colposcopy via and biopsy, you have to see, you follow that see and treat programs whenever the patient comes to you. But if the patient's report is ASCH and HSIL, then you have to follow this patient and do the colposcopic directed biopsy. Now, if the report is LSIL, then here also you have to follow up with HPV, then co-testing, colposcopy, and colposcopy directed biopsy according to the flow chart. So these are the very simplified flow chart, and I must congratulate FOGSI that they have given so much simplified that this report has come, then what to do, how much to where to treat, and how to follow these patients. Then very important is many times we get the unsatisfactory smear. The next slide, please. So here, whenever we get the unsatisfactory smear, you have to review the HPV report if it is available. Then if it is negative, then you have to undertake the routine screening. But if it is positive, then you have to again follow the same protocol. If HPV test is not available and patient is less than 30 years, you have to repeat the cytology in 2 to 4 months. And if the cytology shows it is unsatisfactory, you have to undertake the colposcopy and colposcopy directed biopsy, and you follow this patient according to our guidelines. You have to do via in this some of the patient if the HPV is not available, and if it is positive, then you have to again go for HPV testing. So then you have to follow the protocols. Then there is a screening with cytology and management of abnormal pap smear whenever there are abnormal glandular cells or atypical endocervical cells. So in these patients, you have to do colposcopy, biopsy, as well as you have to do endocervical sampling and endometrial sampling as well. And if it shows no CIN2 plus abnormal cells or any cancers, you have to do co-testing and cytology every 1 to 2 years. And if they are both of them, they are negative, then you have to return to routine screening. If it is either of them, they are positive, then colposcopy and biopsy and manage as per the guidelines. If this endocervical sampling shows it is more than CIN2 plus or cancer, then you have to manage accordingly. Now, whenever it shows ASCUS is between 30 to 64 years, and you have to undertake HPV test again. And HPV test, if it is negative, you have to follow these patients every 5 years. If it is positive, colposcopy and biopsy. And colposcopy and biopsy, if it is normal, you have to undertake in these patients co-testing, HPV testing at 1 year. And if colposcopy is abnormal, you have to manage as per the previous guidelines. You have in these ASCUS patients, you have to follow this patient next for cytology at 1 year. And at 1 year, if it is negative, then you have to routinely follow this patient every 3 years screening with cytology. Whereas if ASCUS, if the report of cytology at 1 year comes ASCUS and LSIL, then you have to undertake these patients for colposcopy and biopsy, which can be normal and abnormal. Then if it is normal, then again you have to follow these patients for 1 year. And if it is abnormal, you have to manage according to the FOGSI-GCPR, follow them, follow up by again via HPV and colposcopy if required. So if again patient, if they are non-compliant, colposcopy, via and biopsy should be done in these patients. So it is a long follow-up, as we have to counsel these patients whenever they come, and many times we see at the periphery that such report comes, the patient gets so much disgusted, they want hysterectomy directly. But our motto is save uterus, and we have to counsel this patient for regular follow-up. Now there are various new modalities like Evalin cervical brush, which can be inserted. Then to collect the cells, there are Delphi lavager, which can release the liquid into vagina and collect the fluid back to the device to collect the cells, or Fournier cervical self-sampling device, which is a tampon-like plastic wand that is also inserted in vagina and turned around to collect the cells. So these are the newer modalities which are available. Now about the HPV test. Now HPV test detects high-risk HPV types either by the amplification of viral DNA fragment or through RNA identification. So these tests, HPV DNA test, identify the DNA of one of the more oncogenic HPV types with direct genomic detection or by amplification of a viral DNA fragment using polymerase chain reaction to obtain copies both conventionally or in real time. And if you see the HPV genotyping, which identifies the specific viral type, usually HPV 16 and 18. The mRNA test detects the expression of HPV E6 and E7 oncoproteins. Now, if you have the facility of primary HPV testing, then it is very nice and good. You are working in a good resource setting. Then if the report is HPV negative, you have to follow this patient for routine 5-year screening protocol. But if it is positive, then you have to undertake this patient for by application of acetic acid. If it is negative, repeat HPV test at 1 year. And if again it is negative, you have to follow the 5-year protocol. But if after 1 year, if it is positive, then you have to undertake colposcopy and biopsy. If VIA is also positive. So if colposcopies and biopsy are normal, then you have to repeat HPV test at 1 year. Okay. And if it is abnormal, then follow FOGSI-ZEPNUR management protocols. HPV test, if it is positive, and you can also undertake cytology. And in cytology, you have to divide this according to the report, like ASCUS or NILM. Then you have to repeat the test every 1 year and follow this only on if you want to do HPV. But you have to have support with either via cytology, or if you have got a facility of HPV 16 and 18 genotypes, you can undertake these testing also. And if it is negative, then again you have to repeat the HPV test at 1 year. So, so they have to find out the colposcopy and biopsy reports. Yeah, always they are supportive to us. Okay, so these are the things we have to do. And many times we do the co-testing with HPV and cytology, and these are the flow chart which is very nicely given if you are doing this co-testing. So co-testing, if HPV is negative, cytology also negative, 5-year follow-up. If HPV is negative but cytology is positive, you have to divide whether it is the report is ASCUS or LISIL, and you have to follow the guidelines like colposcopy and biopsy, or you have to repeat the co-testing at 1 year if it is ASCUS or LSIL. Sometimes you get the report as HPV positive and cytology negative. In that, you have to repeat again co-testing for 1 year. And if, or you have a facility of HPV genotyping and other HR HPV, if it is positive, then you have to repeat the co-testing at 1 year. So these flow charts are excellent, and just follow these flow charts, or you can put them at your clinic, colposcopy clinic. They are very, very useful. Now, these are the another thing you should remember, that primary HPV, this is a simplified chart. If the primary HPV screening you are doing, and if it is type 16 or 18 positive, you just undertake colposcopy. Or if you have 12 other HPV positive, you undertake cytology, and then you have to, if cytology, NILM, you have to follow up in 12 months. If primary HPV screening is negative, you have to take up the routine screening. These are the another new algorithms for cervical cancer screening, that HPV testing negative and positive. If it is negative, you have to repeat test after 5 to 10 years. If positive, then you have to take cytology. As positive, then you have to do colposcopy and treatment. If it is negative, then you have to repeat HPV testing after 1 year. If you have the facility of biomarkers, if they are positive and negative. So these are the very nicely formulated guidelines of our FOGSI, and there are other newer modalities which are HPV based screening, like vaginal cell collection, then E6, E7 mRNA, DNA methylation, DNM, and marker of aberrant S phase induction. So there are various options available, advantages are there, and most of them, their efficacy is excellent, but there are limitations that sometimes with vaginal cell collection, the inadequate samples are possible, and it is always woman dependent and reluctant to use a medical device. And in some of like E7 mRNA, they are very, very expensive, and some of the various things are available only in the research setting. Just to mention that these are also HPV based screening modalities available. Now, if you see the risk of progression with cytological abnormalities, you just remember this chart, that why this long-term follow-up is very, very important. And we have to have always supportive treatment or supportive screening modalities which helps us, like we cannot do on the HPV, and if it is negative, we can follow them after 5 years. But if the cytology is positive, then if LSI, we have to follow these. You can just see the progression from CIN2 plus to CIN3 plus and invasive. So if you have all the facilities, definitely you can stop this progression, and by the modalities like see and treat, and this one we are going to see today's demonstration on thermocoagulation, then definitely we can stop the progression of these cytological abnormalities. Now, the sensitivity and the specificity of screening test, you can see the PAP, it is 40% sensitive, 99.25 specific, and positive predictive values around 35.29, and negative predictive values around 19.39. So if you combine PAP, VIA, and VILI parallelly, the sensitivity comes to around 100%, and specificity 85%, and positive predictive value is 6.38, and negative predictive value is 100%. So we can combine the test also. Now, whenever we are choosing the most appropriate screening test in your practice, so what are the facilities available to you, whether you are having backup of good cytotechnician, all those things matter, and your own capability of taking smear. So if you are doing screening by the cytology, so you have that quality indicators like diagnostic accuracy, training, coverage, and follow-up. And if yes, and if your patient can afford HPV testing, you can undertake the HPV testing. And cytology, if you have colposcopy, you can undertake the colposcopy and biopsy. And do you have the facilities for triage? Triage is very important, means you can follow this patient with cytology or VIA, and also you can treat this patient. So the affordability and your training and the quality all depends, and which you can choose the appropriate screening test in your practice. So just I want to say about this, that we are 35,000 gynecologists. If you screen 5 women per day, 1,75,000 women can be screened daily in India, and 5,25,000, more than 5 populations which are eligible for screening screened per year. So together we can eliminate cervical cancer in 1 year. And is it possible? Definitely it is possible. 8th March, we did a cancer screening all over India for the police personnel. And I'm very proud that FOGSI undertook this. And Bhagya is doing very real work in this for the prevention. And I just want to mention that for the first time ever, the world has committed to eliminate the cancer. And there is a formal global launch for the global strategy to accelerate the elimination of cervical cancer, that is on 17th of November 2020. So Bhagya has done excellent work in this, and she had declared about the slogan competition, essay next slide please, essay competition and painting poster and all. I think she has received overwhelming response. Let us join, everyone, all gynecologists join, screen the patient and treat the patient. And I end my talk. The India is a land of diversity, and this is reflected also in the varied practices followed for the cervical screening. So at some setting we do VIA, in some setting we do cytology, at some setting we do colposcopy and biopsy. And FOGSI has brought up through its GCPR in the low resource and good resource setting, the very nicely done the protocols and follow-up charts. I congratulate FOGSI Oncology Committee for this, and thank you very much for the patient listening. Maybe my audible, I was audible because I was talking through my mobile. Thank you very much.
Thank you, Dr. Vidya. That was a great session. You were very audible throughout the session. I think you gave us a very good idea on the screening modalities for cervical cancer. Now, just to have to provide some expert comments on this, I would like to invite Dr. Sabhyata Gupta, to give her comments on these screening guidelines. Also, I'll give a little bit of an intro about Dr. Sabhyata Gupta. She is the chairperson and chairperson of the Department of Gynecology and Gynec Oncology in Medanta, the Medicity in Gurgaon. She is also an adept gynecological oncologist and is the president at the Fertility Preservation Society, India, and also the president at AOGIN, India. Her field of expertise is gynec oncology, fertility preservation, robotic surgery, and laparoscopic surgery. She has also contributed to various textbooks, national and international journals, delivered lectures, and presented personal work at various international and national conferences. So I would really like to welcome Dr. Sabhyata to give her expert comments.
Thank you, Dr. Nedun, for those kind words.
Yes, you're very audible. Please go ahead, Dr. Sabhyata.
Yeah.
Thank you.
So, Dr. Vidya has very elaborately covered the topic. And what I want to say is that since we are preparing to march ahead towards the elimination of cervical cancer, so what we need to know is that depending upon our resources, we have one thing or the other worthwhile to offer to all the ladies. To the young ones, the young girls, it's a vaccination. To others, we have screening and we have management protocols in place and all the capability we have. So I think there's no reason that we'll not be able to eliminate it. So whatever resources we have to give the best out of those resources to the ladies, and let's march ahead. And we heard all the screening protocols. We are going to listen to all the management protocols. So I think we'll go ahead with that now.
Perfect. Thank you. Thank you so much, Dr. Gupta. So now I would like to go over to the next section. Dr. Lata Balasubramani will be introducing our next speaker, who's Dr. Smitha Joshi. And Parvati, maybe you can have Dr. Smitha Joshi's profile for on the screen. So I would also like to introduce Dr. Lata Balasubramani and give a few words about her. She's a proficient gynecological oncologist currently working at GKNM Hospital in Coimbatore. She has completed her MD in OBG at Grand Medical College, Mumbai, a subspecialty in gynecological oncology at the Royal Marsden Hospital from London, and also MRCOG in obstetrics and gynecology at the Royal Hallamshire Hospital from Sheffield. Thank you for joining us, Dr. Lata. Over to you.
Good evening, organizers, and thank you very much for having me on the program. I'm not sure whether you'll be able to see me. I'm traveling, but it is my great pleasure indeed to invite Dr. Smitha Joshi, who I've known for quite a while. She's a senior scientist at Prayas, Pune, and works as a program director and a project consultant at Ruby Hall Clinic, Pune. She's been awarded the UICC Fellowship at IR and the FOGSI Fellowship at Brown University, USA. She has more than 50 publications in national and international peer-reviewed journals, and I know her because she has a passion for cervical cancer screening, and I cannot think of a better person to speak on this particular topic. Dr. Smitha, the floor is yours.
Thank you, Dr. Lata, for those kind words. Can I have the option for sharing the slides?
Yes, Dr. We'll just share it here.
And I would also like to thank Dr. Bhagyalakshmi Nayak for giving me this opportunity today to talk to all of you. It's been a wonderful session. So I will be speaking on thermocoagulation for the management of cervical intraepithelial neoplasia. Now, across the world, this terminology, thermocoagulation, it's actually used interchangeably with other names as well. So thermocoagulation is also known as cold coagulation. It is in fact a misnomer because it is heat coagulation. It is used, it is also called as SEM cold coagulator. This is the terminology that was used by Dr. Kurt SEM way back in 1960s. It is also called as Cervix coagulator, and recently it is called as thermal ablation, and WHO has acknowledged the fact that this modality uses ablative treatment, and therefore they have recommended us to use thermal ablation. Although even in my presentation, I'll be switching between these two terminologies depending upon the terminology that was used by the authors of the papers, or we have been calling it as cold coagulator because we started using this treatment modality way back in 2010, and we've been using it for the past 10 years since it was introduced to us by IARC, and I must mention Dr. Shankar Narayanan and Dr. Partha Basu and all the screening group at IARC who have been instrumental in driving our program. So although this treatment modality is recently got, there's a lot of interest in using this treatment worldwide. This modality is not really new, as Dr. Usha Saraiya also mentioned. And it was used way back in 1960s by Dr. Kurt SEM. He was a German scientist. And the initial publication about this SEM cold coagulator dates back to 1983 by Dr. Duncan. And subsequently, Dr. Duncan published two important papers. And the first one was about the efficacy of this cold coagulation for the treatment of CIN3 disease. And this was a retrospective analysis of about 1,600 women who were treated for CIN3 disease, and the follow-up was done by cytology. And the primary success rate for the treatment of CIN3 was over 90% at 5 years. The second publication is about the efficacy of SEM cold coagulator for the treatment of CIN1 or 2 disease, again based on very long experience of 13 years, and this was used in a see and treat policy. That means colposcopy and treatment during the same visit,
And this analysis also involved more than 1,000 women who were treated for CIN1 or CIN2 disease, and the overall success rate was over 95%. And a few developed CIN3 at follow-up. So we've been listening that all these women who received treatment need a long-term follow-up of almost 20 years subsequently. The most recent meta-analysis of studies that included thermal ablation treatment for the management of CIN included studies from LMICs as well, because initially the treatment modality was more commonly used in Europe, in South America, and with advancing interest in this technology, more and more low and middle income countries have also started using this treatment modality. So 23 studies were included in this meta-analysis that was done by IARC, and this involved more than 10,000 and 6,000 patients treated for CIN2 and CIN3 disease, and the overall success rate was more than 93% for the management of CIN2 plus disease. So for the management of CIN, we have ablative treatment and excisional treatment. So under ablative treatment, we have cryotherapy or thermal ablation. And under excisional treatment, the most commonly used treatment modality is LEDs or LEAP or cold knife conization in certain cases. And there is an ongoing study, which is a randomized controlled trial that is comparing 3 treatment modalities, that is cryotherapy, cold coagulation, and LEAP. And the study is being done in Africa, in Lusaka and Zambia by Dr. Partha Basu and the screening group of IARC. And the pilot phase of this study has already been published, in which 750 women were randomized to either of the 3 treatment modalities. And the success rate was almost similar in all the 3 treatment modalities. The study is still ongoing. So WHO has recently published the guidelines for thermal ablation, and I will quickly go through the guidelines that have been led by the World Health Organization. And the first recommendation is to use either LEDs or cryotherapy or thermal ablation to treat all women with histologically confirmed CIN2 plus disease, provided the lesion is eligible for ablation. And this is the most important aspect to understand, that for treatment with the ablative treatment modality, the lesion has to be eligible, and I'll be talking about the eligibility criteria subsequently. The second recommendation is to use about 100 degree centigrade temperature for 20 to 30 seconds, and we can give as many applications as required to cover the entire transformation zone. So treatment of the entire transformation zone is important, even though we are using ablative treatment or the excisional treatment. The second recommendation is to use ablation in exceptional conditions. That means when the lesion is not eligible for ablation, but when LEDs is not possible or referral to a higher center is not possible, you suspect there is going to be a loss to follow-up. So ablation can be used in exceptional cases when the lesion is not eligible and when LEDs is not possible. The third recommendation is to use either thermal ablation or cryotherapy to treat women in the screen and treat program. And when not eligible for the ablative treatment, LEDs can be used even in the screen and treat program. The fourth recommendation is to not use routinely antibiotics. So routine use of antibiotics is not recommended with either of the 3 treatment modalities unless there is any infection or you suspect that she is likely to develop infection, for example, a patient who is anemic. The fifth recommendation, WHO suggests that trained nurses, midwives, and healthcare workers, as well as physicians, can perform thermal ablation in order to ensure that we provide this access to screening as well as treatment to large number of women. And I'm very happy to mention that our nurses have been using this treatment modality for the past 10 years without any really serious complication or recurrence of disease. And frequent training makes them really perfect. I've also visited Barshi several times, and the nurses at Barshi, Nargis Dasta Cancer Memorial Hospital, they're also very excellent in screening as well as treatment. So as we talk about elimination of cervical cancer, we have to increase the coverage of screening, and it's not possible for the doctors to reach all the places, and it is essential that we train our healthcare workers for screening as well as treatment. And the sixth recommendation mentions that in settings where LEDs is available, use LEDs over ablation for the recurrent disease. So whenever there is a recurrence, if LEDs is possible, that should be preferred over ablation. So principles of treatment of any CIN, either use of ablative treatment or excisional treatment, remain the same. And the first and the important principle is that whole transformation zone must be treated. And the transformation zone is the area between the new squamocolumnar junction and the old squamocolumnar junction. So this entire transformation zone must be treated even if the lesion is present only in one quadrant or two quadrants. The minimum depth of treatment should be around 7 millimeters because most of the lesions, even the high-grade lesions, extend up to 5 to 6 millimeters. And with ablative treatment modality, in 70 to 80% of the cases, we reach the depth of about 5 to 6 millimeters. And surveillance of treated patients is necessary for the next 20 years to see whether there is recurrence, whether there is failure of treatment, or if there is no disease. So there are certain eligibility criteria for ablative treatment, and as we have seen the WHO guidelines, this treatment modality can be used for any grade of CIN. Even CIN3 can be treated by ablative treatment, provided certain eligibility criteria is followed, it is not missed. The first and the important criteria is the lesion should be visible on the ectocervix. It has to be a type 1 transformation zone. In some situations where we are suspecting loss to follow-up or when it is not feasible, even in type 2 transformation zone, we can treat by ablation in order to reduce the loss to follow-up. The lesion should not be extending into the endocervical canal or to the vagina. It should be occupying less than 75% of the ectocervix or less than 75% of the transformation zone. So less than 3 quadrants of the transformation zone should be involved by the lesion if you are planning to treat by ablation. There should be no evidence of suspicion of invasive cancer or any glandular abnormality. Do not treat when there is pelvic inflammatory disease at the time of treatment. However, routine or vaginal discharge, if it is there, the treatment can be done, and you can give some antibiotics following treatment. Otherwise, routinely following routine treatment, antibiotics are not recommended. And the woman should not be menstruating at the time of treatment, and she should not be pregnant. So I'll go through some of the slides to show you how to determine the eligibility for ablative treatment. So in this first slide, this is before application. You see the cervix before application. You can see the squamocolumnar junction here, and this is after application. So you can see an acetocyte lesion which is occupying about 1 or 2 quadrants of the cervix. And the lesion is on the ectocervix. It is not extending into the endocervical canal. It is not extending to the vagina, and therefore this lesion is eligible for ablative treatment. Here again, you can see the squamocolumnar junction very nicely. There is probably a low-grade lesion here on the upper lip as well as the lower lip. but the lesion is still not covering the entire TZ, probably covering about 3/4 of the transformation zone. This is after application of Lugol's iodine, and this lesion is eligible for ablative treatment. So you can either use this ablative treatment in a screen and treat program where you're using either VI or an HPV test as a primary screening test, or in the screen see and treat program, or in the biopsy confirmed lesion. So you can take a biopsy from the acetowhite lesion near the squamocolumnar junction and from the area which appears more dense acetowhite, and then you can immediately treat that lesion, and the histopathology report may be available at a later date, but you have at least treated that lesion. If you look at these two diagrams, here you see the lesion is entering into the endocervical canal. The squamocolumnar junction is not visible. It's the lesion is involving all 4 quadrants of the cervix and looks like a high-grade lesion. Even in this diagram, the lesion is involving all 4 quadrants of the cervix. The lesion is entering into the endocervical canal. We cannot see the squamocolumnar junction. So these lesions are not eligible for ablative treatment. So what is important to get very good success rate with the ablative treatment is selection criteria of the patient. And if it is followed, this works really well even in the HIV population. This looks like a benign lesion or a low-grade lesion, or maybe squamous metaplasia. This is after application of acetic acid. There is a small acetowhite lesion on the upper lip. There is probably small lesion on the lower lip of the cervix, but the squamocolumnar junction is visible. The lesion is on the ectocervix. This is after application of Lugol's iodine, and thus the lesion is eligible for treatment with ablation. This ablative treatment, thermal ablative treatment, has got certain advantages over cryotherapy, except for the cost of the instrument. However, cryotherapy requires recurrent expenses for refilling the refrigerant gas, which is not required for thermal ablation. So there are 2 different companies that are making this thermal ablation unit, about which I'll be talking a little later, but the cost varies between 2 to 4 lakhs. But there is no recurrent cost for the instrument once you have the instrument. The instrument is electricity operated as well as a battery operated version is available. So if you are going to use that in the clinic setting, the electricity operated version works very well. But if it is a field setting, it is better to have a battery operated version. The treatment time with thermal ablation is shorter. For cryotherapy, it is always 3 minutes of freezing, 5 minutes of thawing, and 3 minutes of freezing again. So the entire treatment requires about 15 minutes, because we have to wait for thawing the probe after completing the freeze-thaw-freeze cycle. Whereas with thermal ablation, 20 to 30 seconds of application is sufficient to achieve the required depth of destruction. And we can give multiple overlapping applications. And there's less discomfort with thermal ablation. There's less discharge with the thermal ablation. So there are several advantages over cryotherapy when we're using thermal ablation. So this is the YSAP Cervix Coagulator. It is made by a German company. This is the switch for switching it on and off. This is the temperature regulator. So here you have the maximum temperature that goes up to 120 degrees centigrade. And as mentioned in the WHO guidelines, about 100 to 105 degrees centigrade temperature is sufficient for ablation, and one single application may be given for 30 seconds. We have been using it for 40 to 45 seconds, but the guidelines mention 30 seconds of application is sufficient, and multiple overlapping applications may be given to cover the entire transformation zone. You also have a display, temperature display here, where we can adjust the temperature. And then this is the probe which can be removed from this tubing. So this is the flat probe, but there are two other probes manufactured by the company. There is one with a nipple, and there is one which has probably the depth of the nipple is slightly more. The one with the nipple has about 5 millimeter size of the nipple. So this is made by the German company, and this is the battery operated version of BiSAP Cervix Coagulator. Recently, for the past 3 or 4 years, Liger Thermocoagulator is also available in the market. It is made by a US-based company, and it's a very compact small suitcase in which the entire instrument can be fitted. It is a battery-operated version, so you have two batteries that are rechargeable. This is the charging station for the battery, and this is for the connection. This is the main handle of the thermocoagulator, and there are two probes. There are 3 or 4 probes that are available. There is a flat probe, there is one probe with the nipple. So this is the assembled unit, and you have a temperature control here, and the timer can be set for 20 degrees or 30 degrees, 20 seconds or 30 seconds. And there is a small light for visualizing the cervix. And this is the probe, and this probe can be detached from the main unit. Even the battery can be removed, and then you can recharge the battery. Once it is charged, you can use it for 30 or 40 patients. So the procedure of thermal ablation is quite simple. As I have mentioned earlier, you can use it in the screen and treat program or the screen see and treat program, or even for the biopsy confirmed lesions, and any grade of CIN can be treated with this treatment modality. So you ask the woman to empty her bladder. She should be lying in the modified lithotomy position, and then insert a self-retaining bivalve speculum. You should either use Cusco speculum or the Graves speculum. Expose the cervix, apply acetic acid, apply Lugol's iodine. If you have the facility, take a biopsy, and then you can treat that lesion during the same sitting. So here you can see the cervix after application of Lugol's iodine, and the probe is covering the entire lesion here in this case, so there is no need for multiple overlapping applications in this case. This is a second case. This is after application of acetic acid. You can see a low-grade lesion on the lower lip. The entire squamocolumnar junction is visible. This is under the cream filter. This is after application of Lugol's iodine. You see a lesion on the upper lip as well as the lower lip of the cervix and maybe laterally. And this is after application of the cold coagulator, or this is after thermal ablation treatment. This is how the cervix looks after treatment. Side effects or complications following ablative treatment, either thermal ablation or cryotherapy, are almost the same, and they're extremely rare if the treatment is performed carefully. There could be mild discomfort or pain in lower abdomen. Vasovagal reactions are very rare. Vaginal burns can only occur if you are careless, if the vaginal walls are lax, and if they're coming in between the probe, then you can use a condom, cut it on the closed end, and then put that condom on the speculum, and then insert the speculum so that the vaginal walls do not fall in your region. Bleeding is again very rare and can occur if you take a biopsy and then treat, but in fact this cold coagulation helps in stopping that bleeding area, or it can occur due to infection and secondary hemorrhage. Pelvic inflammatory disease is very, very rare. We haven't seen more than 1 or 2 cases of PID in the last 10 years, and cervical stenosis is also very rare. Post-treatment instructions following thermal ablation are very important. The discharge that is experienced by women is relatively lesser as compared to cryotherapy, but she should be advised that she should expect some watery discharge or reddish or yellowish discharge. There could be mild cramps in abdomen, which is something similar to the menstrual pain, and they can use a sanitary pad if the discharge is causing a lot of discomfort. The important thing is to avoid sexual intercourse for the next 4 to 6 weeks, but if they cannot really follow abstinence, then they should be advised to encourage the male partner to use male condom as well. And they should report for a follow-up examination 3 weeks after treatment, 6 weeks to 3 months after treatment, and then screening at month 12. So they should report back to the clinic if they have fever for more than 2 days, bleeding for more than 2 days, if there's foul smelling purulent discharge, or if there's severe pain in abdomen. In our experience, none of them actually had any severe complication following treatment, and all there were very few side effects or complications, and that could be managed very well. As we have been hearing since the first lecture, that follow-up of all women treated for CIN is very, very important, and they need a long-term surveillance of almost about 20 years. So at the follow-up visit, when they come back to you, they should be called between 6 months to 12 months. We call them after a year. So HPV testing is the best option at the follow-up visit because it can predict treatment failure or cure of the disease. Co-testing, if it is available, that is again very good. Or if HPV testing and co-testing is not available, then repeat screening with cytology or VIVLE. You can do the routine conventional follow-up if the screening test is abnormal, so colposcopy, biopsy from abnormal areas, and repeat treatment if again the lesion is eligible or LEDS or LEAP is preferred as per the WHO guidelines for the treatment of residual or recurrent lesion. Cleaning and disinfection of the probe of the coagulation unit is very, very important, but it is very simple. You can train the healthcare providers to do that. This chart shows cleaning of the probe of the Liger thermocoagulator. So this probe has been removed from the instrument. There is a cap that comes along with the probe, so we must cap the other end of the probe properly, and you should not allow water to touch that area of the probe. So cap the probe properly, clean the probe with normal saline, and then wash the probe under running tap and water. You can use soap if there is a lot of debris attached to the probe, and then dip the probe in Cydex for 20 to 30 minutes. And after 20 to 30 minutes, you can again wash the probe under running tap and water, again repeat with normal saline and heat it, and then you can reuse it on the next patient. If this Cydex business is not possible in a field clinic, then what is recommended is cleaning the probe with saline and then spirit. You can use mild detergent, use soft cloth or cotton to clean the probe, and then heat the probe at 100 degrees centigrade for 1 minute. And for the Liger thermocoagulator, you can set the heating cycle for 20 or 30 seconds or 40 seconds. So depending upon the setting, you see that the probe is heated for 1 minute. And at this temperature and heating for about a minute, it denatures the protein. So the protein is denatured above 60 degrees centigrade. So you can clean this heated probe if required, and then reuse it on the next patient. So that was my last slide, and thank you very much.
Thank you, Dr. Smitha Joshi. That was very informative. I believe we have a video to be shared. So, Parvati, can you please go ahead and share that video?
Yes, give me 30 seconds.
While Parvati is getting that ready, right after the video is played, Dr. Usha Soraya, ma'am, it would be a great honor if you could give a few comments to Dr. Smitha Joshi's presentation. So right after the video there, Dr. Soraya, ma'am. Thank you.
Oh. Sorry, there seems to be some sort of a technical issue.
Okay. In that case, maybe we can move on to the next presenter, and maybe after at the end of the session, if we have some time, we can play that video. Thank you, Dr. Smitha Joshi again. So, Dr. Usha Soraya, would you please come in and say a few words?
Can you hear me? Am I audible?
Yes, ma'am. Yes.
So congratulations, Smitha, for a very nice study and a very nice presentation. And I'm glad to see that you have a 10-year experience of this instrument. And you must be having a very good follow-up also. So I want to know, what is your biopsy rate generally? How often do you take a biopsy before doing this? So when do you correlate the two findings? Because biopsy may take some time to come. And I would, of course, like to know your recurrence rate in the first, after 6 years.
Yeah, thank you very much. So whenever we are using this modality in the clinic setting, we always take a biopsy. But if we are screening women in a field setting, in a field camp where we have a mobile screening unit that goes to different communities, and when we've used VI as a screening method, we've not taken a biopsy. We did that initially, but then it becomes very messy in the field setting. So in the clinic setting, there is no harm. We can always take a biopsy and then treat. And the histopathology report is available afterwards. About recurrence, we have experience of using this treatment mainly in HIV positive women as well. And we've seen about 80% success rate at the end of maybe 3 years. We've now almost completed 10 years of follow-up, and the main risk factor for recurrence is the persistence of HPV infection. So as you know, in HIV infected population, persistence is a big issue, and we are yet to analyze our data of 10 years follow-up of HIV infected women. But the recurrence rate is very, very low in the general population, provided the selection criteria is very good. And therefore, I took some time to explain the selection criteria. And you'll see recurrence if the selection criteria is not really followed. Otherwise, we've seen women have started coming back for the follow-up, and we've not seen more than, say, 5% recurrence rate in the general population.
What would be the age group of your patients? Have they finished their childbearing, or do you allow them to get pregnant afterwards, or what is?
No. Yeah. Generally, childbearing is over by the time they're 30. So we are screening women between 30 and 59. So there's hardly anybody who is yet to conceive, and except for one HIV infected patient who was she was not treated with ablation. She was treated with leads, and she's trying to conceive now. I suppose she is conceived. So childbearing is not a problem after ablative treatment, and leads only if that there is increased risk of preterm labor if the depth of cone is very Otherwise, there is no such effect on the fertility.
Anyone else has any queries? Maybe you can ask right now.
Madam, there is a question. Can we use a normal underwater coagulation? So I think Dr. Smitha can tell. So I think that works a little differently. That's a surgical instrument in which we use to coagulate the blood vessels. So I think that I have no idea whether it can be used in cervical lesions. But I think that's the option. We can think about that later. In case you don't have the thermocoagulator, we can think. But we have to have the restriction on the temperature. So if we know that the temperature is not going beyond the 100, so I think we can think about using and that too again in an experimental setup. Yes, I can't see any more questions in the chat box. I'll just check.
Yes, I think that's it. One question on the temperature setting, but I think Dr. Smitha Joshi already mentioned that in her presentation of 100 degrees Celsius. So I think that was answered by Dr. Helen in the chat. Thank you, doctors. Our next session is an interesting case discussion. This is related to thermal ablation with comments from some expert panelists. I would first like to request Dr. Maninder Ahuja to invite our next speaker. Maybe Parvati, if you can have Dr. Pauline's bio up on the screen for Dr. Maninder. So a little bit about Dr. Maninder Ahuja. She is the director of Ahuja Hospital and Infertility Center as well as Ahuja Healthcare Services. With over 40 years of experience, Dr. Ahuja is an expert in adolescent, high-risk pregnancy, infertility, and menopause medicine. She's an active part in all professional organizations dealing with women's health, like FOGSI, ISAR, IMS, and ISPAT. So please, Dr. Maninder Ahuja, over to you.
Thank you. Thank you, Dr. Abhilakshmi and organizers. I have joined from the mobile. I think I am audible and visible also.
Yes, madam. Yes, madam.
Okay. So the first thing which I want to say, congratulate both the speakers. They spoke very well and extensively. And one point which I liked about Smitha Joshi was that it is time that we have to train our paramedical people. Our nurses and healthcare workers, they have to be trained to do the VIA and perhaps thermal ablation also, because we have to reach out to a big size population. And since the time of mortality is reduced, we cannot say that we are being effective. So with that, I think just adding point, it's my pleasure to introduce Dr. Apollo Mukherjee for the thermocoagulation, a new concept in the management of precancer lesions of the webinar. And she's an experienced consultant and oncologist from the Department of Surgical Oncology at Cervix Cancer Hospital, Assam, and she has been doing research studies on early detection of cancers in cervical, oral, and breast to find the preventive methods. I think that is a very, very, futuristic research they are doing for the preventive methods. That is the area I think we should be more concentrating on, because prevention is always cost effective. And she has also national journals based on cancer and to improve the quality of life. Dr. Pauline has notable achievements in the field of oncology. So, mic is all to you on the webinar, Dr. Pauline Mukherjee.
So, I think Dr. Pauline is having some issues, so let me introduce and she'll go ahead. So, Dr. Parimala is an experienced gynecologist and colposcopist, and she actually works very hard for cervical cancer prevention. Is an ex-assistant professor from Bangalore Medical College, past president of Bangalore Society of Obstetrics Gynecology, co-chairperson of the 2018 ISCCP Bangalore Conference, and she holds the Guinness record for doing the highest number of pap smears in 2015. So let us all applaud. And so we go ahead with the next panelist of today, and she is Dr. Jeannie Gan. And she is again a very experienced gynecologist, urogynecologist, senior consultant, and has an interest for endoscopy as well. And she has a lot of work, but then I think she has a special interest for preventive oncology, especially cervical cancer. So welcome, Dr. Jeannie. So next one, Dr. Helen. Helen is she is a very enthusiastic person from the far northeast from Imphal. And she has been working very hard and has been trying to actually spread awareness in her part of India. So welcome, Dr. Helen. Next. I think, and Dr. Bindya is an experienced and certified CPC IARC oncologist, associate professor at UCMS and JTB Hospital, and I think she has been in touch with many organizations which are working for cervical cancer prevention. So without wasting much time, so let's go ahead with the presentation. So
thanks to all my panelists, Mala Devi, Dr. Ziti, Dr. Helen, and Dr. Bindya. Extremely sorry for this technical glitch. So we start on with just a few general questions before I start with the case. Why is this cervical cancer screening program not taken up in India as a national program? I might start with Dr. Parimala Devi. Ma'am? Ma'am, am I audible?
Yeah, please. Dr. Parimala, madam.
Dr. Parimala, cervical cancer screening has not taken off such a program in India. What is your opinion regarding this? All right. I shall move on to Dr. Zini and then come back to Dr. Parimala, if that's okay. Dr. Zini.
Hi. There are two or three. Hi, Dr. Palumi. I think the biggest, there are two or three reasons for it. One is that the women's, outlook towards having cervical screening. They're very reluctant to come forward and have the cervical screening done. Secondly, I think, of course, it is a monetary issue. If, we have a lot of people below poverty line living in our country. So who funds for these pap smears for these women? So I think both of these, the reluctance of the women, the lack of awareness is the third reason that women do not understand the importance of the pap smear, which we are trying to spread as much as we can. So the three factors are there for the lack of the uptake of a cervical screening program.
Right. So I'm going to give Dr. Bindya, I welcome you to the dais. Methods of cervical cancer screening that would apply to your setup.
Hi.
Dr.
Bindya, thank you, Dr.
What would be the methods of cervical cancer?
Yeah, hi. So I'm working in a government medical college, which is a tertiary care facility, and in our hospital, we are using the VIA and the pap smear. We don't have an Hpv screening facility in our hospital, so this is what we are using right now.
All right. I would also pass on the question to Dr. Helen. What kind of methods does apply to your setup when we are talking of cervical screening? Dr. Helen?
Yes, thank you so much, Dr. Polemy. We use the conventional Pap smear and VIA sometimes. Recently, we have acquired a colposcope also, so we are hoping to put it into good use. But we don't have HPV DNA testing facilities.
All right. So if
we know HPV
right,
in.
Thank you so much. Has Dr. Yes. Dr.
Yeah,
Helen?
we are using the HPV.
Yes, Dr. Bindya, you were talking about HPV testing. Right. Is Dr. Parimala, has she been able to join the, has she been able to join the session?
Hello?
Yes, Dr. Bindya, you are audible. Yes, Dr. Bindya, go ahead.
Yeah. So we are using the HPV only when we are doing the research projects. Right now we are only using HPV in those setups. Otherwise we are using the conventional cytology and VIA.
All right. Thank you so much. Do we have Dr. Parimala? Has she been able to join the session? I believe ma'am has done the maximum number of Pap smears a day, and this has been recorded in the.
I think she has left. You can call in Dr. Vidya. She is there. Dr. Vidya, are you there?
All right, Dr. Vidya. Yes, Dr. Vidya, ma'am, that was an excellent. So we'd really like to have your comments. Dr. Vidya, are you around? Dr. Vidya?
No, so please go ahead with. Yeah.
Sure. Okay. So now we have sort of rounded up the challenges in cervical cancer screening, and I agree to what Dr. Zini just said. It's the stigma that's associated and probably lack of awareness and the education. So we go on to this first case. Can we just move the slide ahead? That's it. So this is a 46-year-old lady, and just a brief thing, this lady has come from the screening program that we run in our institute. Ours is also a rural semi-urban based hospital, and we run a program that is in lieu with the ICM, population-based screening. So this lady had a screening for positive for VIA, and we brought her for colposcopy. Now this is under a program, and this is all funded. So again, put it on the board. It's also called a modified read score, Dr. Zini.
I didn't catch your whole question. I think you lost it. Could you?
Am I audible?
I lost you. Can you please repeat your question?
Oh, I'm so sorry. This is the profile of the lady. Yes, and this is topic picture.
I can't see the picture.
It's a VIA and
okay, fine. Okay. Yeah.
Parvati, please move the slide.
All right, you have to.
Please move the slide.
All right.
All right. So the question is, I would just like you to comment on the sweet score. How useful is the sweet score?
I think for an untrained eye, see the way I have been trained, I've been trained in the traditional method. So I look for my acidic acid uptake, how slow or fast it is, and then move on to my Lugol staining as well as the green filter look. Now, for an untrained eye, I think sweet score is an excellent score, but I think sometimes you end up over-scoring. But I think it's been well proven in literature that both sweet score as well as the read score, there is evidence that both of them work very well. So according to looking at this picture, they're almost all four, I think at least 75, with all three quadrants are at least involved in the transformation zone. The uptake of acetic acid, if you look at it, it is frankly milky white, and then if you look at the leukocytin, again, it is distinct yellow. The margins are sharp. So, of course, we go for a sweet score of 5. So, yeah, I think it is quite useful, and there is evidence to suggest that, yes, it is a good way of deciding how severe the lesion on the cervix is.
All right. I would ask Dr. Bindya, what would be the cutoff for you to decide whether there is a high-grade possibility of a high-grade lesion? Dr. Bindya?
Yeah, so on the sweet,
am I audible?
Yeah, you're audible. Yeah, Dr. Mukherjee. So on the sweet score, we normally take a biopsy if the sweet score is 5 or more. So in our setup, so and where the sweet score is between 5 to 7, the chances of positivity are for a CIN2 lesion are around 70%. But if the sweet score is 8 or more, in that case, the possibility of a high grade CIN is definitely almost to the tune of 90 to 95%. So in our setting, we and in the literature also, if the sweet score is 5 or more, we should take a biopsy because the chances of detecting a pathological lesion is much more higher in those settings at that cutoff. Hello?
Right. Thank you so much. Okay, Dr. Helen, we have taken a biopsy from this lesion. Again, Dr. Helen, am I audible?
Yes.
Dr. Helen?
Yes, I can hear you. Yes, I can hear you.
Right, Dr. Helen. See, in our setup, we cannot send the patient back and forth. So what we do is we take punch biopsies and you consider see and treat policy for this patient. Dr. Helen, with a sweet score of 5, would you consider a see and treat policy for this patient, or would you like to send her back and await policy the biopsy results?
With a sweet score of 5, yes, we can go for a see and treat procedure in this case. But yes, biopsy report would be appreciated if it can be done.
Right. So what procedure, suppose let's say the patient will not come back to you and you are opting for a see and treat procedure. So what procedure are you going to, use? What I mean is between excisional and ablative procedure, what is the one that you're going to use? What is your option?
Ideally, if I go for excisional, there is some preparations that are required, but with ablative method, it is an OPD procedure which I can use even in a campsite. So ablative definitely recommended, but in my setup, usually I go for excisional because I do have facility for that, but I do not have a thermal coagulator yet. So yeah.
Dr. Mukherjee, I would like to, I'll go for an ablation because this lesion is very much amenable to ablation. And like in the CM3 program, we should first go for ablative methodology method, then excision. And in case it is not available, that's a different thing. But since it is available in our facility, we will definitely go for an ablative treatment as per the guidelines.
I slightly.
All right, Dr. Dean, you agree to?
I slightly disagree with Dr. Bindya on this one. Either I will take a biopsy and then do an ablation, but because the sweet score is 5, and as Dr. Bindya herself mentioned that there is a 70% chance of this lesion being CIN2 or above, then I would probably go for an excisional method with a leaf or a LETS, because then I will get a biopsy report as well. The second thing I would like to take into consideration are a few factors. Although there is no proven effect on fertility and everything, I would like to take into account what the patient's age is. If the patient is less than 40, less than 30, 35, and she's not completed her family, maybe I can think of more on lines of ablative method. And also if she is likely to return to follow-up and get a repeat, PAPs and everything, then I think I'm more happy to do biopsy and do ablation. But if this patient is less likely to return to follow-up, if she is more than 40, I will probably go for an excisional method so that I get a biopsy as well as I give her a more definitive treatment and reduce the chances of cervical cancer for her in the future.
I had heard in Dr. Smitha's lecture. So if you do ablation or you do excision, the cure rates are the same for CIN2 and above. And also, when we do an ablative therapy, because we have the facility for biopsy, we take a punch and then do the ablation if we know that the patient is not going to come for follow-up. So as a universal, like what I want to give the message is that for a screen and treat policy, because it is recommended that ablation is the first method of choice for a screen and treat program. So, like what even Dr. Smitha Joshi also told in a lecture, so we should convey this like that ablation is the first choice for a screen and treat program.
No, I agree. If you take a biopsy and do an ablation, that's perfectly fine.
To take a punch and then ablate the lesion.
All right, can I intervene?
Yeah, that's fine.
Dr. Zini and Dr. Vindhya, can I just
go ahead.
All right, this is not a debate. I would like comments from everybody. Let's not.
We're not debating. We just wanted to make it a thing.
Lack of time here. But yes. But I agree. See, I will give you the evidence. The question is excision more effective than ablation? There are two meta-analyses on this. One is 2013 and one is a very recent meta-analysis, 2018. Now, what the current meta-analysis says, this has compared the LEAP with ablative procedures, mostly cryotherapy, and it said that in women with CIN, treatment with LEAP was associated with a significantly lower risk of persistent disease at 6 months and recurrent disease as 12 months when compared to treatment with cryotherapy. But there have been other studies which this particular meta-analysis does not take into account, and that was included in the 2013 study. And with all of that, the other studies said there's not enough evidence to say which one is better. So they have always left it as an open-ended, a thing for the institute, that it depends on the institute's protocol and your resources as to which one you actually choose.
Patient profile. See, anything that we do has to benefit the patient. So always I would suggest that take the patient profile into account.
All right, let me just finish. Does the excision have a greater morbidity than ablation? That also has, we have backups to this, which says that no significant difference in complications or selected adverse effects were found in meta-analysis. So I think both the parties are right in their respective setups as to what they are going to, provide the patient with. And definitely true, we always have at the back of the mind the risk whether we are missing a pre-invasive, whether we are missing a micro-invasive cancer. So this patient, I'm sorry, since it's under a program, we do a pap smear and a punch biopsy together, though this is not a regular way how things should be done. So her pap smear was low-grade intraepithelial lesion, but the biopsy was hyperplastic stratified squamous epithelium. Now, what we did is we thermocoagulated the lesion, but then that's our institute, so patient was not ready for a LEAP procedure. So this is how we manage the patient. We go on to the second case, and what I'm going to do is, because of lack of time, I'm going to move on to case number 3. Parvati, can you give me the slides for case number 3? Yeah, so while she's doing that, I'm going to so this is a 34-year-old lady, and she has had one full-term normal delivery. She has completed, she has regular menstruation, not completed family. Now, she came into the OPD with complaints of spotting after the coitus. So these were her complaints. She was not screen picked. Pelvic examination, next slide please. It showed an ectropion. There were no significant discharge. The area at 6 o'clock grossly bled to touch. Pap smear, this was an office procedure that we did, was reported as ETFIL. So how do we manage next? Now I'm just going to change the order. Dr. Helen, if you have a patient. Dr. Helen?
Yes. This is a 34-year-old female, and she already has one living issue. Fertility might be her first concern also when she presents with a condition like this. So thinking about her, we would like to try her out. So it will depend on the infrastructure we have. So like in my setup, so I can ask her to undergo HPV DNA testing, or I can go ahead with colposcopy guided biopsy. I think I'll go with colposcopy because I have colposcopy in our department. So
Right. Dr. Bindya, would you agree?
Yeah.
Or would you like to do something else?
No, we'll go for a colposcopy.
Right. Dr. Zini as well, would you agree with the colposcopy straight up?
Yeah, colposcopy. Yeah, definitely. First step is colposcopy and then plan further management.
Right. So Dr. Helen mentioned HPV. So if you are in a setup that can afford HPV,
definitely yes.
For HSIL, I will not like to go for an HPV because it shows a high grade lesion. If we it shows that it is a high risk. I mean, it's not alter the management. HPV testing will not alter your management. So HSIL indicates it's a high grade.
No, but it doesn't alter the management. But what I could, if it is negative, I might advise the woman to get vaccinated if she is affording enough.
Right, she's 34 with one full-term normal delivery. I would reconsider the vaccination. You're considering vaccination for the patient?
If the HPV is negative, why not vaccinate her? The FOGSI-ZEPNUR guidelines are clear that we should vaccinate anywhere age between 9 to 45. So if it is HPV negative, you will treat now and reduce the future chances of her getting HPV. Even if it's an HSIL.
All right. So according to you, when we get a pap smear, we do the HPV and then take her up for colposcopy. Is that what I understand, right?
I do the HPV and then the colposcopy at the same sitting.
So can we have the colposcopic pictures? Right. So the next slide, please. Yeah, right. So surprisingly, there wasn't really that significant uptake on VIA or the lupus iodine. So this was the picture. The thing is, I would like to just confess a small point here. See, I did not get the patient to write a consent for sharing her pictures. So I fished out some pictures that look similar to what her colposcopic picture was. So that is a small confession. We have this issue of patient, pictures going on the public domain. But on the whole, it looks something like this, not very significant. So, right. So what we did was a leap procedure because in our setup, HPV is not possible. And biopsies, we were seeing there was a discordance in the colposcopy as well as the pap smear findings. So we did a leap procedure and the specimen was reported as HSIL. Now, I would ask this Dr. Helen. So when you get, when your pathologist reports on a leap procedure, if this is your report, is there anything more that you would like to be commented on, Dr. Helen?
Can you come with the question again, please?
Yes, Dr. Helen, we have done a leap procedure like you have advised. Taken her up for colposcopy. We have added a leap procedure to it, and the specimen is reported as HSIL. So is there anything more that you would want to know from the pathologist, or you're happy to accept this as your report?
I think I'll go ahead with the report because this is a 34-year-old with a fertility issue.
One full-term normal delivery.
Yeah. So
and there is a mismatch between, pap smear says HSIL, but on the colposcopy, you're not really seeing any significant change, anything significant that you can pin your guns onto. So we did a leap procedure because under our setup, this is what we thought was best for the patient. So the specimen is HSIL. Dr. Bindya, would you like to comment on the histopathology? Is there anything else that you would want from the pathologist?
You mean to say the histology was histopathology was HSIL, so that means it's the lesion is CIN2 or more. So it's a high grade lesion. So I would like to the pathologist comment and what is the margin status, whether the margins are also positive or whether the margins are negative of the disease, and that is the most important aspect of a leaf specimen. And obviously the dimensions, what was the length, and whether it was a single piece leap or it was out in like one or two how many pieces you need to take out the specimen in. That is also very important. The comment on the margin becomes difficult. The margin is the most important for a leaf specimen.
Absolutely. Yeah. So the orientation of the specimen is the most important thing when you're doing it. It does not matter if it comes in 2 or 3 pieces, but you have to orient it properly, and the pathologist has to give you the margin based on the orientation. So this patient is on follow-up. Parvati, you have to skip 2 slides up. Now she returns after 12 months and with similar complaints. And this is the period post-lockdown, so she was not able to come to us for follow-up. So the pelvic examination, what we found was cervical erosion again. The pap smear was HSIL. So Dr. Zini, question to you, how do we further manage this patient who's 32 years old?
I need to know what were the margins before.
We don't know the status of the margin.
We don't know. Okay, then again, go ahead with another colposcopy. In fact, if I don't know the margin status, then my second, on the follow-up visit, it has to be a pap smear accompanied with the colposcopy without fail. So I just wouldn't do just a simple pap smear.
Right. So the patient had come to you with this HSIL report. Now you're going to take her up for colposcopy. So what if you get a repeat colposcopic finding? Now my question is, suppose you do get a lesion that is high grade, would you subject her to a repeat excision? Now this is a patient, why I want to discuss this is a patient who has not completed the family. She's 32 years old. She's had a LEEP procedure 12 months back.
I would repeat her to another LEEP if the colposcopy suggests so. Okay. The reason I may do a little biopsy first in this situation to confirm my findings of the colposcopy of CIN2 or higher lesion. Because if you look at the evidence, that what is the evidence after even a cone knife biopsy or after a LEEP? After a LEEP, the risk of miscarriage or what we are worried about basically is cervical incompetence is not very strong. So if the first biopsy was not very big and if she still has a reasonable length, then it first depends on what my colposcopy findings are. If the lesion is small, I probably do I'll do a biopsy and an ablation. If the lesion is very big and involving all 4 quadrants or at least 75% quadrants, I might consider a LEEP. So it depends on my colposcopic findings.
All right. Dr. Bindya, would you, Dr. Bindya, am I audible? Yes. Would you agree to the management that you...
Hello? I can't get your...
Yes, Dr. Bindya. Would you agree to the management? Dr. Dini just shared her management protocol.
Yeah, I'll also do a repeat...
Absolutely.
I'll also do a repeat colposcopy and if I find a lesion... Yeah, I'll also do a repeat colposcopy and if I find a lesion again, if it's a lesion is there, then I'll take a biopsy and if it comes out again at high grade, then I will go for a second LEEP. Because, post-LEEP, doing an ablation, I don't know how effective it will be to destroy the 7 millimeters because there's a lot of fibrosis. So I will opt for a second LEEP if there is a high-grade lesion again.
Yeah.
Right. So the risks, the fertility...
Probably as I think what me and Dr. Bindya are trying to say is that we won't go for see and treat at the same setting. Yeah, we'll probably do a biopsy and then confirm our findings of the colposcopy and then proceed to LEEP if need be.
Yeah. Right, absolutely. Well taken.
Yeah.
I just had another query. How would you convince, while you are discussing this, the treatment for a repeat excision procedure, would you sit down and talk to the patient about the fertility aspects of it, the side effects of it?
Definitely.
Or how does in your experience, how many patients have actually said, have actually gone ahead with the procedure after, after you discuss the various aspects, the side effects of having a re-excision?
you have to tell them, you give them it's all about informed decision in this day and age. Okay. So when you have to sit down with the patient, give her the options of the treatment. She may decide she wants to go for an ablation procedure. Now, if you actually look at the evidence for ablation procedures as well nowadays, whether it is properly done cryotherapy or whether it is thermal coagulation, then in that setting, if you look at the evidence, there is a 90 to 95% success rate if it is done in the correct manner. The only worry that I have particularly in this patient is because in the first colposcopy, I didn't see much on the ectocervix. So I do not know what is the depth of the lesion in this case. So I will probably counsel the patient in those lines that it may be that the disease is more into the cervical canal, which probably will benefit more. And then, yes, life is more important than, fertility we can manage. There are things people after hysterectomies have had babies. Yeah. So we can do a cerclage and all if need be, monitor the cervical length during the pregnancy.
So,
and then take it from there.
Side effects is not worrisome to that extent and can be circumvented.
Yes.
So this case was basically to bring out the fact that the higher rates of persistence of the disease are most commonly associated with positive margins. And that is something the pathologists need to be trained on to comment on the margins. Again, the human HPV DNA positivity, especially with HPV 16, 6 months or more post-treatment, and this is also the cause of persistent disease with negative margins. The other lesser factors are large-sized lesions, which involve greater than 2/3 of the cervix, surface of the cervix, and lastly, the endocervical gland involvement. So these are the certain factors that we have to keep in mind when we do the procedures. All right, because we are running a little short of time, I'll wind up the session by the last question to Dr. Helen. Dr. Helen, am I audible?
Yes, please.
So which are the patients for whom you will consider a hysterectomy when you get, say, a CIN3 lesion? So your biopsy, you have an adequate lead biopsy that says CIN3. Now, which are the patients for whom you will consider hysterectomy?
Women in their perimenopausal age group, ones who have completed their family, has no fertility issues, definitely can be considered. Plus, hysterectomy per se in CIN treatment is not a recommended treatment option. Usually, it's accompanied by other gynecological conditions, which usually calls for the hysterectomy. So, if we consider CIN only, CIN3, and then the patient wants to undergo hysterectomy because fertility is not an issue, or she's in perimenopausal age group, then definitely we can consider. Plus, HPV testing is also another factor. Pap smear showing persistent infection. Definitely, this patient has high risk of developing cancer in the future. Right. So, these are the kinds of patients that we should consider.
Thank you, Dr. Helen. Dr. Bindya, do you want to add some more points to this? Any potential candidates for hysterectomy? Apart from the post-menopausal age group, someone who has a CIN2+ lesion?
See, basically, if she has a coexisting other uterine problems, like if she has an adnexal mass, she has an AUB, in that case, hysterectomy is the treatment. Otherwise, you've treated her well, excision, you've treated the cervix. That is what it is, and your margins are negative if you're on your second leap, if you're doing the second leap, and your margins are negative. Right. So in that case, you don't need any further treatment. So hysterectomy should only be reserved for whenever there is another coexisting uterine pathology. And because even after hysterectomy, she has to follow up with smears. Because if we are doing a hysterectomy for CIN3, so she still needs a follow-up. So hysterectomy per se is not the treatment for choice for CIN3.
Absolutely. And what if you come up with a patient who emphatically states that she cannot come for any follow-up and does not, she's premenopausal, completed her family? Dr. Dini?
My first thing whenever I'm choosing hysterectomy of choice, I completely agree with Dr. Bindya. My first thing always is taken into consideration is patient's age. Secondly, I will take into account her socioeconomic status also, how frequently she can come for my follow-up, because everything, it costs in this day and age. Third thing I will take into account is what is the status, what is her obstetric history, if she has completed her family. And fourth, of course, I will take into account if there are any other associated gynecological issues. Fifth, what is her HPV testing? Okay. And if the patient is less than 40, I am always very reluctant to do a hysterectomy, because one of my special interests is urogynecology. I do not want to subject a woman to menopause, vault prolapse, because that is one of the complications which we gynecologists sometimes bring upon, because an early hysterectomy sometimes does that. But then I think you have to individualize the treatment, taking into account the patient profile. So while it may be completely correct for a postmenopausal or a late perimenopausal inpatient, it may completely be wrong for a 35-year-old lady, even if she's completed her family. So I think you have to take those things into account.
Yeah, and Dr. Paulomi, we have I would like to just put one thing. Absolutely, I agree with Dr. Rini. We have to be very reluctant in offering hysterectomies for treatment of CIN3, because, you remove the uterus, the woman thinks that she doesn't need to come for follow-up.
Yeah.
It's very, very important that you have to tell that even after hysterectomy, you have to follow up with smears and all, because being in a tertiary hospital, we have had patients who have undergone hysterectomy for CIN3 and they've come with ball cancer, after 10 years or so. Because they think the uterus is out, they don't need to follow up anymore. Yeah. It's very important you do any kind of treatment, they have to be followed up at least for 20 years post-treatment, because they are the ones who are at high risk for developing cancer.
Absolutely, Dr. Bindya, thank you so much. Just my last slide. These are, can you just skip some more slides? So I would like to say potential candidates for hysterectomy. These are from the various papers that have seen the profile of patients and the up-to-date. What they say is what our panelists have emphatically stated, that any CIN 2 and 3 with positive excisional margin who have completed childbearing and in whom an excisional procedure cannot be performed. Very, very important. A recurrent or a persistent CIN 2+ who have completed childbearing in whom a repeat excisional procedure is not feasible or desired. Thirdly, a scarring or the shortening of the cervix from prior treatment that prohibits a repeat excisional procedure. So basically, you have to attempt an excisional procedure unless there are absolute contraindications to it. And lastly, it of course doesn't have very many takers, the unwillingness or inability to comply to long-term follow-up. Thank you very much to all my panelists. And with this, I end the session. Thank you, Bhagyalakshmi ma'am, for giving me this opportunity to conduct the session. Thank you very much.
Thank you so much.
Thank you. Thank you so much.
Thank you all. So up next, we have an international speaker all the way from Salt Lake City, USA. Dr. Dean Wallace is the president and CEO of Cure Medical USA and is also a clinical assistant professor at the Department of Pathology and Department of Surgery in the University of Utah. Over the years, Dr. Wallace has collaborated on several publications, and Cure Medical is the manufacturer of the handheld Thermal Coagulator unit, which we'll be showing you a product demo of later shortly. And we hope that our association with Cure Medical, we can assist in their vision to provide cost to tackle women's healthcare. So over to you, Dr. Wallace.
I appreciate the opportunity to speak to you today. And really enjoyed the previous presentation. Smitha's covered many of the areas that I'm going to cover and done a great job at it. So I'll be quick in those areas. But I think everyone is very familiar with the issues and cervical cancer and worldwide. It's one of the greatest threats I think that we have. It's unfortunate that the pandemic COVID-19 is impacting some of the work that we're trying to accomplish in this area. We've teamed up with the World Health Organization to be able to eliminate cervical cancer by 2030, and I'm very interested in working with the obstetricians, the gynecologists in India, because I think there's huge opportunities to make an impact worldwide, especially in India. So the other thing is it's a very preventable disease, and if managed effectively, we can make that happen by 2030, I believe. So this is treatment choices for treating pre-cervical cancer. Smitha has already addressed some of these issues here. The two major techniques for treating pre-cervical cancer is excision or destruction. I won't go into the different areas other than what is used most prevalent now, which is the LES or LEAP procedure, and that's a universal application for any of the CIN diseases or lesions. And then there's the destruction, which thermal coagulation, I believe, is the most practical procedure that we have now that can realize treating these lesions. Cautery, of course, has been explained earlier, is similar procedure, but I don't think it's been shown to be very practical at least in rural areas, especially in Africa. So to me, Smitha's already covered the type treating and so forth. We can treat type 2 transformation zone as long as it's fully visible in the endocervix and the probe can reach those. Again, it's less than 75% of the ectocervix. For reasons that's already been explained, the cryotherapy has not become very effective because of the problems of supply of gas, the cost of the gas, and getting the large tanks in different areas, especially in Africa, has been very problematic. And then the time for treatment, I think, is a big issue. With the 3 minute freeze, thaw, freeze makes it a fairly long procedure compared to thermal coagulation, which can be done in less than a minute, the procedure. I think Smitha's already covered all these conditions for the destructive treatment, so I don't think there's any reason for me to go into these. And the advantages and disadvantages of it are spelled out here in this slide. It's simple and cheap. The disadvantage, of course, to that is that you do not have a sample of tissue that can be taken, looked at histologically to find out if the whole lesion was excised, which you can do with, of course, the LES procedure, but not with the destructive thermal or cryotherapy. The equipment's widely available. It's very portable and easy to use now, and the cost has come significantly down. Disadvantage is, of course, without histology, you can't make sure the diagnosis that you could if you had a sample of tissue. It's not possible to rule out cancer or glandular disease, of course, because you don't have the sample. And there's always a question about we're not having a histological sample, whether or not the depth of the excision or the depth of the ablation is adequate or not. And you don't have, of course, the margin status. Again, Smitha has covered extensively and did a great job in explaining the guidelines now with thermal ablation that is available, or that the World Health Organization issued in the end of 2019. And I think most of the world now is accepting that thermal ablation now. Again, it's a very practical approach because it's simple, lightweight, and portable, and can be done in 20 to 40 seconds. Again, they recommend a 20 to 40 second treatment period at 100 degrees centigrade. Just a little history on how the Liger thermal ablation, a thermal coagulator, was developed. About 5 years ago, Dr. Walter Prindeville came to me and said he needed and he was working with IARC at the time, still is, and asked me to help develop a practical system to be able to treat in the developing world the precancer cervical lesions. And so I worked together with the team at IARC to develop the Liger thermal coagulator. Sankar and Partha, India, were very instrumental in helping develop this device and get it right to make it practical, inexpensive enough to be affordable, and a simple instrument. The clinical trials, there's a number of clinical trials that's being done. The main one is the one in Zambia that is first phase of it has been published, and as Smitha, I think, summarized those results very well, so won't spend time on that. That is published in the Lancet. If anyone would like to be able to go read that and get the details of that study. It's in phase 2 and phase 3. Eventually we'll have over 4,000 patients in that study. But the preliminary results of over 700 patients is out now, and they're not seeing any difference in phase 2 and phase 3 of the results on that. Here's a thermal coagulator. It comes, as Smitha's already pointed out, with the handle, the main handle part that has a microprocessor and all the control system that that goes through when it's started up to make sure all of the functions of the electronics and the probe is properly and gives working, and that it will give a indication if there is a problem and with the probe or the handle or the battery's low before it's placed in the patient there. Comes with 2 rechargeable batteries that can recharge in 1 to 2 hours, so one can be used while the other is being charged if needed. And 30 to 50 patient treatments can be performed. Tip sizes, we followed the World Health Organization specifications for the sizes in their publication for cryotherapy, so they're similar to those probes that were used for cryotherapy. And there's 3 different versions of that. One is a 19 millimeter flat tip, and then a 19 millimeter nipple tip that has a 5 millimeter nipple or raised portion that can be held mainly in the cervical os. It's not to treat endocervical lesions, it's to help center and hold it in place. And again, as Smitha pointed out, it's very important and crucial that the whole transformation zone is treated. And then there's the 16 millimeter flat tip for satellite lesions that can be picked up with a smaller tip in overlapping applications. I think field testing is extensive now. We're in over 58 countries. Thousands of these handles, our Liger thermal ablations, are in use now throughout these countries, including Asia and Africa, India. Not so many in India, and we hope that we can expand the use in India. And there's Smitha shown treatment with a 19 millimeter probe that had a nipple on it there. I just want to briefly do a comparison. As you, I'm sure, aware, there's 2 units out and available now. One is the YSAP, the new generation C3 cold coagulator, and then ours, the Liger medical thermal coagulator. They're similar in their applications, but there's a few features that I'd like to point out that I think I would be appreciative to IARC for the input and the PATH organization, PATH organization, that helped us develop the Liger one so that it would be practical in use for treating these precancer cervical lesions. One is that we're using state-of-the-art technology and being able to heat the tip up in less than 10 seconds, around 6 to 8 seconds, it will heat up. So what that means is that the probe can be placed on the cervical lesion after VIA or after identification of the lesion that needs to be treated, so that it is placed at room temperature onto the cervical lesion. So that avoids you being able to inadvertently do any damage to the vaginal epithelium there, because it's placed in at cold. And then the button is pressed a second time, and then that starts the heating, which is, we feel, is important, and this is again input from the PATH organization and IARC, is that it heats up the cervix so that it gives it time to accommodate. So we believe that causes less pain and shock of putting in a 100-degree centigrade probe onto the cervix all at once. I think that's is proven to be of value to both the patient in terms of the pain and the shock or the heat, as well as giving it time for the cervix to accommodate to that heat, heating up in the 6 to 8 seconds that it does. And then the treatment then goes on with a timer that times out for the 30 seconds. We do have the option of being able to go between 20 and 60 seconds, so the user can change that, which is not available, I think, in the YSAP unit. The second thing I would point out is there's many other issues here in terms of the feature. This, by the way, was this chart was provided to us by PATH, so this is not a non-biased comparison of the 2 units. The second I'd point out is that the YSAP unit requires a sheath, an external sheath that goes on, because they do heat. It is heated at 100 degrees centigrade when it's placed in there. So to avoid any heating of the or inadvertent vaginal epithelial contact, that sheath is placed on and placed in. Now, what that means to the user is that now that's a second device that has to be cleaned and sterilized, or high-level disinfectant, which their unit cannot be autoclaved. The probe cannot be autoclaved. It's just a high-level disinfectant. So that means there's two pieces of equipment or device probes that have parts that have to be disinfected. The third area I just point out would be the cost. The thermal coagulator is significantly less expensive to the end user, and in the kit it contains everything that's needed to do the procedure, while the YSAP unit is more expensive and does not include the battery operated. That has to be purchased separately, and so there's additional cost to that. So I'll get off my soapbox here of trying to promote the device, but we hope that we've done it so that we have developed it so that we have a practical system for thermal ablation. The other thing I want to just briefly touch on is those lesions that cannot be treated by ablative therapy, that needs the LETS procedure, excision procedure. Again, this was part of our work with IARC and providing a complete system for treating cervical cancer lesions is to have an excisional device, and that's what the electrosurgical unit that we developed is portable and compact. It has everything in the kit, in the bag that comes with the device, that makes it very portable and practical. Has a grounding pad as integral part of it. It has a smoke evacuator that is integral part of the device. It's compact and small. Can be placed on the side of this pad is the grounding pad that goes under the patient, so that you don't need another grounding connection pad. The pencil is standard pencil and standard loop electrodes to do the LETS procedure. So everything is contained, and it is also, we feel, cost effective. So I think I've covered all that. Battery power, no tethered wires are needed, no external power supply. It's a battery operated. Again, 2 batteries come in the kit so that you can do around 15 patients per battery, while the other battery is charging up again and can be charged in at any power wall source the batteries can in the world. So, all right, just in summary then, as I mentioned before, Liger Medical has joined with the World Health Organization to eliminate cervical cancer by the year 2030. That's our objective. Our charter is to provide devices at affordable prices to the end users. Therefore, we have a general policy of non-exclusive dealers so as to keep the prices as low as possible for clinicians to have accessible to these devices. We're happy to work with ZEPNURhealth in India, which we have done so for the past year, as they seem to have this same philosophy. We hope that as a team we can accomplish our goal to provide the best quality instruments for treating cervical cancer, cervical precancer lesions at the lowest prices to the clinicians to make it affordable and practical for them. There's many organizations that we're working with. I've listed there the UNAID with the CHI, USAID, PEPFAR, PSI, PCI, UNICEF, EVPA, AF, PINK, the World, the Women's Health Program in Cameroon, Center for Cervical Cancer Prevention in Zambia with Dr. Grossbeck Parham, and has been one of the main advisors and help helping us make sure the device works properly, even though he's totally independent. We rely heavily on the input from him. Again, I mentioned the PATH organization and numerous universities that we also have worked with and many nonprofit humanitarian groups. So with that, I'll turn the time back to you, Karen. If you have any questions, I'm happy to answer those when we have time. Thank you.
Excellent. Thank you. Thank you, Dr. Wallace, for that presentation. And we are hoping as well that we can contribute and help with the reduction of cervical cancer cases in India. I just wanted to get Dr. Coagulation
Yeah, Dr. Shankar is here, so we can hear from him actually, from the horse's mouth, who has done all the studies on thermocoagulator. So sir is here, so we can hear from him.
So while we get that organized, I'll just give a quick brief about Dr. Shankar Narayan. He's actually a radiotherapist and a clinical oncologist. He's currently senior officer, the visiting scientist at WHO IARC, France, and the NHM expert for cancer programs, Tamil Nadu. He has provided technical support to more than 100 countries on early cancer detection, vaccination, and cancer control. He is also the recipient of the Ernest Wertheim Award in Austria, Princess Lala Salma International Prize Morocco, Paul B. Corbone Award for International Oncology USA, and British Colposcopy Society Founders Medal from the UK. He has more than 280 publications in international peer-reviewed journals, such as the New England Journal of Medicine, Lancet Oncology. So we would love to hear from you, Dr. Shankar Narayan.
Yeah. Thank you very much, Dr. Bhagyalakshmi, and the organizers for the opportunity and for your kind words. And thank you, sir, for your kind words. I think it's an excellent webinar, and we heard very comprehensive presentations on cytology as well as on thermocoagulation, the thermal ablation for the management of invasive, pre-invasive lesions. I think quite a lot of progress has been made, and people are always talking about the elimination of cervical cancer. And actually what WHO aims is, before 2030, all the countries would have implemented HPV vaccination to cover at least 90% of the girls below the age of 15 years. And at least 70% of the women would have been screened at the ages 35 and 45, with 90% of the cervical precancers treated. And then about 90% of the invasive cervical cancers, the diagnosed invasive cervical cancers, are treated. So these input measures are supposed to be in place in all the countries, all the signatories of the World Health Organization by 2030, so that eventually you will see cervical cancer brought down to less than 4 per 100,000 over a period of time. And some of the countries will achieve the elimination much more faster, like for example, Australia is expected to achieve elimination by 2028. But many of the low and middle income countries will achieve, if they succeed in putting these interventions in place by 2030, they may achieve this in the next 30, 40 years. So it all depends upon how comprehensively the interventions are put in place. And in that context, the management of cervical precancerous lesions, thermal coagulation has, the thermal ablation has a major role. And it makes treatment much more feasible and possible and acceptable and safe. And this is a highly portable instrument. Whichever thermal ablator that you use, you know, it is a highly feasible method of treating cervical precancerous lesions. And there is a misconception that thermal coagulation cannot be used for treating CAN3 lesions. It is not true. You can treat CAN2 and 3 lesions, and the criteria for the selection of cases is essentially depends upon the type of the transformation zone and the clinical extent of the disease, as very clearly explained by Dr. Smitha. And the collaboration that IARC had with the Liger is an excellent example of a public-private partnership. And actually, I had to undergo almost 2 to 3 years of negotiations with the WHO legal department before this collaboration can be established, because I had we had a grant from the National Cancer Institute in the United States, which helped us to develop, to contribute to the development of the handheld thermocoagulator in close collaboration with Liger. It is very nice to hear from Wallace today. And Dr. Walter, as Wallace said, Dr. Walter Prantival, whom I consider as the father of loop electrosurgical excision procedure, had a major role to play in this, because he was the senior visiting scientist at IARC when I was heading the early detection prevention section and the screening group. And we had this grant from the National Cancer Institute, and we established this collaboration with Liger Surgical. And the prototypes were evaluated in several places, and finally we have a product. So at the moment, both VSAP as well as the Liger have portable units which are available in the market. And I think thermal ablation has a very important role to play, and it will live up to its expectations. And we have to also take into consideration a change in the scenario, because whether we like it or not, whether there are substantial criticisms or not, HPV vaccination is going to be a reality. I think the Indian vaccine should be available by the end of next year, hopefully, and which will totally transform the vaccination scenario across the developing world. So eventually we will come across a situation where there are very few 16, 18 HPV infections, and mostly they will be the non-HPV 16 and 18, which will cause transient infections and transient low-grade lesions. And in such situations, the treatment has to be highly selective. You will come across smaller lesions and things like that. So thermal coagulation has an important role to play in future in the post-vaccination scenario. And Dr. Smitha, she was one of our very important collaborators who did a pioneering study in evaluating thermal coagulation both in non-HIV and HIV-infected women. And we have all this information on the HIV-infected women, both from her studies and Dr. Sahasrabudde's studies in India, as well as in sub-Saharan Africa. So we have an enormous wealth of evidence pointing towards the efficacy, safety, feasibility, and acceptance of thermal ablation, and it is time to implement. And this is a highly affordable instrumentation, medical instrumentation, and highly affordable forms of treatment. I think I would encourage every gynecologist who practices cervical cancer screening to have a thermal ablator, whichever brand they choose, depending upon the price band, and whoever provides you with the most affordable pricing. You can have a unit, and you will do a yeoman service in reaching treatment to women who have been detected with cervical lesions, which is one of the major missing links which has made screening unattractive and ineffective in many places, because the link between screening and treatment was a very, very challenging task. And I'm very glad to say the Tamil Nadu Health System Project, which runs a massive screening program in Tamil Nadu, is now switching over from cryotherapy to thermal ablation. And in Africa, many of the countries, because I was very closely associated with Zambia, encouraging them to switch over from cryotherapy to thermal ablation, and they have now totally replaced the ablative treatment towards thermal ablation, which is possible, which has been made possible because of the commitment of the government as well as the experts within the country who supported, as Wallace pointed out, Dr. Manahamuntu and Dr. Grasbeck Barham were instrumental in such initiatives. So finally, I would like to thank Dr. Bhagyalakshmi for the opportunity to address, because the way that we went into thermal ablation is, I remember very well when in 2000, when we were initiating all these studies in the developing world, Dr. Fatsauta called me and told, why don't you use thermal ablation? But I regret not listening to him at that time. And then we started using thermal ablation only about 10 years back, when we were not able to afford to maintain cryotherapy service in many of the African countries because the gas was very expensive, and the availability, the supply chain for the gas is something which is untenable in many places. Anyway, we have a good solution for the management of cervical precancerous lesions, which we should adapt and go ahead with. Thank you very much for your kind attention.
Thank you, sir.
Thank you, Dr.
Hi, this is the demo of Thermal Coagulator. Thermal Coagulator comes in this steady case. Let's open it. So this is the entire content for the Thermal Coagulator. Inside you can find one main unit, 2 rechargeable lithium ion batteries, one charger, and 2 probes. One is 19 mm flat probes, another one is 16 mm flat probes. This is the main unit, which is handy and easy to use. The first step is connect the battery into this main unit. Second step is connect the probe into this unit. Now the machine is ready. To switch on, click on this button. Now the LED turns on. This helps to locate the lesion on the cervix. Now to start the treatment, you can find the blue light here. Insert into the vagina and locate the lesion. Once you inserted, click on the button now. It starts heat and it reaches 100 degrees Celsius in 8 seconds. It is indicated by blue light. The treatment time takes 20 seconds. Every 5 seconds, the light goes off, so you can track the treatment procedure. Once the treatment is done, you can hear the beep sound and you can remove it. Now let's perform the same procedure in this chicken breast. First, switch on. Locate the lesion. Click to start heat. Wait for the treatment. Done, which is very simple. You can find the tissues ablated perfectly. This unit requires less maintenance. You cannot feel the heat at sides of the probe. When fully charged, you can perform 10 to 15 cases. You can have one battery as backup. Please contact ZEPNURhealth for further queries.
Just finally end it off. I just really want to thank Dr. Bhagyalakshmi because she really went out of her way to get this organized and assisted us with every step of the way. I know we went a little bit overboard, but thank you all for your time, and it was a wonderful session. Also, regarding the Thermal Coagulator, we've shared that in the chat. The product is available online, and whoever is interested to learn more about the product, we can definitely assist with that and help this cause further. Thank you all, and stay safe and happy Diwali to everyone. Thank you.
Happy Diwali.
Happy Diwali.
Thank you everyone. Happy Diwali.
Thank you everyone. Dr. Nidun, Dr. Malarara madam is still there, Dr. Sabyata. So thank you everyone, Dr. Bindya, Dr. Ginny, and thank you for sharing.
Thank you, Dr. Bhagya.
Thank you so much.